you already know we are short of time because the exam has been in a way preponed in the other years. So total number of, actually not the number of months, but at least 20-25 days we are losing. We in physiology still few topics are left. Among them renal physiology, those topics are left we are doing after a long time. So I'll just revise first whatever was done, just revise in that has to be done in very short again because actually there is less time. So anatomy, what was done was anatomy of the physiological anatomy of the renal system, so kidneys, okay, and topics like glomerular filter, what is glomerular filtration, what is glomerular filtration rate. If you go by the NMC curriculum, then these have been done. Glomerular filtration rate, factors affecting those, okay, these have been done, but just quick revision. So this is the gross structure of the, that means the cut section of the kidney. This what are renal papillae, what do you mean by renal cortex, outer side, medulla, the structure of a nephron, what are vasa recta, what are peritubular capillaries. If you don't keep this in mind, then the next discussion again will become difficult for you to understand. So as we are doing after a certain, there was a certain gap, so peritubular capillaries are present, which we call peritubular capillaries, the capillary system or the after the efferent arteriole in case of the cortical nephrons. In case of the juxtaglomerular nephrons, these are called the vasa recta. So we'll have to study about the reabsorption and countercurrent mechanism. So there this importance of vasa recta will again be that is you will understand. So what is the importance of vasa recta? So this is a structure of a, probably this is the structure of a cortical or juxtaglomerular, cortical nephron, because what we told, thin ascending limb, the portion thin ascending limb after the group of Henle, this is very short or absent in the, this is shorter nephrons. In the juxtaglomerular nephrons more or less prominent, but in the cortical nephrons not very prominent. So this is a cortical nephron, and what is going downward is the inside the inner medulla. This is the juxtaglomerular nephron. So long loops of Henle. So just recapitulate this. These again food process podocytes, all these things, these food processes, these called podocytes. Podocytes at the basal layer of the glomerular basement membrane, through which the actual, there are filter pores through which the actual filtration process occurs. So what will be filtered? Whatever is coming in the afferent arteriole, filtration is occurring, the substances. And what is the filtration rate? It is, what is the filtration rate? How much? 125 ml per minute. That comes to 1800 or 1.8 liter per day. Juxtaglomerular apparatus we have already discussed. This, the basic four processes, amount filtered, some substances, most substances will be reabsorbed. If in case of in one substance, filtered minus whatever is reabsorbed, that is taken back. Where it will be taken back? Through the tubules into the blood in which either the peritubular capillaries, and the peritubular capillaries in case of the juxtaglomerular nephrons are called vasa recta. So sekhane reabsorption ta hobe, so reabsorption, and whatever is secreted from those peritubular capillaries into the tubules constitutes the amount secreted. So for any particular substance, amount filtered minus amount reabsorbed plus amount secreted is what is excreted. This is just common sense. So much so is filtered, so much so is secreted, so much so is reabsorbed. So secreted will be add to the filtered, but subtraction is the reabsorption part is subtracted. Filtered minus reabsorbed plus secreted is amount excluded. Based on this, go the concept of clearance. The concept of clearance told that It is not the amount of the substance, it is the virtual amount of plasma which is cleared of that substance. You remember this virtual amount of plasma, that means whatever is coming through the artery, the plasma concentration of any substance, say any substance X, into its into the renal artery flow. That means flow of blood through the renal artery. Whatever will be entering through the renal artery will go out either through the urine or through the peritubular capillaries, and the renal vein ultimately will go back to the general circulation. So, renal plasma flow in arteries, in the artery, concentration of the substance plus urinary flow rate into volume. From this we can get the concept of clearance. If a substance is wholly cleared, it is that by definition is the virtual amount of plasma which is wholly cleared. All these have been done, we are just repeating. So, this then will be 0 because we are just considering, just hypothetically, the substance which is wholly cleared, that is, it will not go back into the renal vein, that is clearance. So, if this is 0, then clearance becomes, when it is wholly cleared, this whole thing is cleared, whatever is coming through that volume is cleared into plasma concentration. That means if it is wholly cleared, wholly cleared means that substance is wholly cleared, that means whatever volume was entering through the renal artery, that volume is cleared, is the virtual volume of plasma. So, that is the volume of plasma which is cleared because the substance is wholly cleared. So, this gives the, so I just told it in short, এখানে কিন্তু আমি একবার মানে just short এ বললাম because these have already been done. Just think, if the whole volume, I am thinking of the virtual volume which is cleared. So, if nothing, that means I am imagining nothing is going back into the body. So, this part becomes 0, then the whole plasma which was entering through the renal artery is cleared, so that this can be written as the clearance. So, clearance of the substance is the virtual volume of the plasma. So, from that this is derived. Where will this be? This one. This comes because this does not occur actually. Actually what happens? Some part goes back into the vein, some part is filtered. But in those substances, in case of those substances where it will be freely filtered, nothing will be left. Like a substance is, one substance like that is inulin. The clearance value will help to measure the glomerular filtration rate because everything is filtered. Okay, whatever comes through the arteries is actually filtered. In case of a substance called para-aminohippuric acid, what happens? This is not freely filtered, but very little amount of it goes back to the general circulation. So, that helps to measure the renal plasma flow. We can't do this. This is in case of inulin. So, substance must be freely filterable in glomeruli, and others is, you can just think about it, neither reabsorbed nor secreted by the renal tubules. If it is reabsorbed or secreted from the renal tubules, then again the clearance, that means whatever is coming out in urine cannot measure my glomerular filtration rate, because I am measuring, because experimentally what I am getting, whatever we are getting, whatever is cleared in the urine, that has been measured, that is being measured. That is giving the filtration rate only when whatever was filtered, just that is coming out in urine. It cannot be reabsorbed or cannot be secreted. So, inulin or to some extent creatinine, to most extents, not to some extent, to most extents creatinine fulfills that criteria. Very little amount of creatinine is secreted also in the renal tubules, but that is ignored. So, creatinine is also considered as such a substance which can consider measure my glomerular filtration rate. And substance must not be synthesized, broken down. That means in the kidney tissues itself, if it is synthesized or broken down, it again adds up or is to the substance amount which has been filtered. So, it cannot measure the filtration rate. and it must be physiologically inert. This is nothing, it cannot be toxic. We cannot do an experiment with a toxic material. If we do have to experimentally measure clearance, it should not be toxic. So those fulfill the criteria when clearance is, that means the concept of clearance is giving the amount of glomerular, helping me to measure the glomerular filtration rate. And when the concept of clear, these have already been done, what are the factors affecting glomerular filtration rate and all, but glomerular filtration fraction, again these are concepts, everything. Filtration fraction is what percentage of renal plasma flow is the GFR. So what percentage? Renal plasma flow is around 700, say 6. So it is taken almost 20%. Renal plasma flow 20% hoche glomerular filtration, that means filtration rate, that means if it is 700 milliliter per minute, then 140, it's 125, 600 to 700 and 1/5 of that. 20% of renal plasma flow is glomerular filtration rate. This again is the just the summary of the renal circulation. Okay. So we'll now just go by. This is not exactly for just for renal physiology. This I have shown just to mention, see, the renal plasma, the renal blood flow among all the blood flow through all the organs. Kidney per 100 gram of tissue, kidneys have the highest blood flow. 420 milliliter per 100 gram per minute, it is much greater than the others. And so blood flow in milliliter per minute, it is also greater than most, except, that means it is greater than the heart also, that is except the liver. Milliliter per, just the rate, because the liver mass is much more. Okay. So per gram of tissue, it comes to kidneys has the highest blood flow per gram of tissue, right, per unit mass of tissue. It is because the kidneys are smaller compared to the total mass of the liver is much more, total mass of the kidneys is much lesser, it is only 300 grams including the 2 kidneys. So this may help you in MCQ type of questions. Per mass, per unit mass, which organs have the highest blood flow, that is the kidneys. But if we think in terms of rate, that means per unit time, then it is the liver, simply because the mass is more, that is simple mathematics. So this we have done. This renal plasma flow, again that is also discussed, renal blood flow, renal plasma flow. Renal blood flow is 700, theoretically accepted value is 700 ml per minute. Blood flow is 1000 to 1300, 1200 to 1300. Renal plasma flow is 600 to 700. I just told GFR filtration factor is GFR by renal plasma flow, not renal blood flow. If I have told renal blood flow, so again, if we know that if you get this problem, renal plasma flow, it is just out of the whole body, if it is 5 liters of blood, then you can just calculate how much percent is the renal blood flow. If we have the renal plasma flow, how to calculate the renal blood flow? How much of blood is plasma? It's 55%. So if it can be done like that. Formula is like 1 minus hematocrit, don't go by that. Simply it is renal plasma. So plasma is 55% of blood. So if this is the renal plasma flow, this is the renal blood flow. Because 55% is that, so total 100% is how much? Simple unitary method. You can, this is simply that will come to 1 minus hematocrit, because instead of hematocrit, what you write, this 0.45, 45%, then simple, that comes to simple. You can do it by the, mostly I encourage, don't go by formula and all, just don't memorize the formula. It is simple. Plasma is 55% of blood. So either way, if blood flow is given, plasma flow can be calculated. If plasma flow is given, blood flow can be calculated. If there is just anywhere, you have to apply this. This is what we were talking about. Para-aminohippuric acid is such a substance which is not freely filtered, but which negligible amount of which goes back to the renal vein. It is 10%. So if you have to calculate the true renal plasma flow, then we use this substance, true renal plasma flow, then we have to consider that that 10% has to be considered, but actually what it is, renal plasma flow through the artery, plasma concentration of pH into renal plasma flow through the vein, because the plasma concentration does not change, and urinary flow rate into urinary concentration of pH. So, what happens if we consider that nothing goes back into the renal vein, then it is clearance of pH will be this, as per the clearance formula. Again, that also we have just understood how. So, this will be the clearance of pH, that equals to the renal plasma flow, But if we take that 10% into account, then what will happen? Then we have to just, if we don't take that 10%, if we consider that nothing goes back, actually pH, how does it come into the urine? It comes into the urine either by what is not filtered, it comes by secretion, and we are most of it, very little, 10% or less goes back. So it is, we are considering it does not go back into the vein. So this part becomes 0. Otherwise, so this is the effective renal blood. If it is the renal plasma flow, if we have to consider that that is not 0, then we have to do it like this. So this will be the, we have to do it like this, then substitute UPH, pH by RPFA minus RPFV. This has to be in the denominator for calculating. If we consider that 10% goes back into the renal vein, but usually it is ignored. That means for all practical purposes, it is ignored. And again, they have mentioned about the Fick principle here. Fick's principle is nothing. As you consider that, nothing means, as you are doing the cardiac output, Fick's principle always tells that the total, that is law of, it follows the law of conservation of mass. The total amount will be the same. So for cardiac output, it is like whatever is going through the pulmonary artery and being oxygenated. That, from that we are indirectly calculating the cardiac output. Just it is following that amount of pH that flows into the kidneys through renal artery, that amount of pH that flows out through urine renal veins. It is true in case of all substances, because there is no other way. Either has to go out through urine, or it has to go to the renal circulation through the renal veins. Okay. So this is just depicting that filtered load. If it is say 60 milligram per minute, it has shown by a number, whatever number. So almost 1/5 of it is filtered, and rest is comes from the peritubular capillaries, or the, in case of juxtaglomerular meninges, from the vasa recta into the urine. It is showing that all of pH is going out. Actually what happens, very little goes back again, okay, through the, it does not, secretion is at least 10% of the total is not secreted. That is, out of 60, say 6, if it is, we calculate 60 is coming into the renal artery, then 6 milligram or something, it is not actually going back into the general circulation. So this is again showing clearance of pH is giving me the renal plasma flow, clearance of this inulin is giving the GFR. Okay, clearance of inulin is given as the GFR. And clearance may vary of any substance, may vary between 0. If it is, if that does not appear in the urine, that means then it will be 0. This is just, again, you can just think of it common clearance of urine. Usually in a functioning, normally functioning kidney, glucose does not come into the urine. So it is, clearance is 0. But if that is totally removed from the blood, then clearance will be the whole amount of the renal plasma which is coming into the arteries. By definition of clearance, it is the virtual volume of plasma which is completely cleared of a substance. Because, why we are telling virtual? Because most substances are partially cleared. But in case of pH, if we ignore that 10%, it is completely cleared. So that is clearance of pH is 700 ml per minute, 600 to 700 if we consider the range. So our renal plasma flow is clearance of para-aminohippuric acid. GFR is clearance of inulin, or to most extent creatinine can also be. Creatinine also 5-10% is secreted in the peritubular capillaries, but still we consider creatinine as a substitute for inulin, because creatinine more or less, ignoring that little 10% or something, that is creatinine also approximates the renal this GFR. So leave this for now. This is just showing the different substances we will require in at some point of discussion. We may require what are the concentration of the different substances in the this plasma. Like this is in milliequivalent per liter, millimole per liter sodium highest. This is in intracellular or extracellular. This is not required for the time being. So how are substances reabsorbed? That from the exam point of view, this is also important. Substances, how they are reabsorbed, the characteristics are different in different parts of the tubule, but just see that the substances are reabsorbed. If you consider it is transcellular route or paracellular route, just understand these points. What is transcellular? It is through the cell. In different regions of the tubule, there are the cells. So through the tubular cell, this is the red dot, where the red dot is now. This is the tubular lumen. That is the filtrate is going out, tubular lumen. So when the substances reabsorb, they have to cross the apical membrane. What is the apical membrane? Which is towards the membrane, towards the tubular lumen side. That is the apical membrane, and the basolateral membrane is towards the blood side, which blood side means the peritubular capillaries. Again, just think of the anatomy. The peritubular capillaries are following the tubules. In case of cortical nephrons, just around the tubule, shorter, say, if we say this means grossly, this is a very compressed area. So small nephrons, shorter, but where there are the vasa recta in the case of the juxtamedullary nephrons. So these are the following the long loops of Henle. So that is the blood side. So that is the substances are absorbed through the transcellular route, or the paracellular means in between these various cells, the gaps in between these are the cells. So through the junctions which we have discussed in general physiology, through the different junctions, this goes to the blood, different substances, and through the tubular cell, this is the tubular lumen, this goes through the, if this goes through the cell, it is transcellular. How will they go? Either by simple diffusion or by, that means like there will be channels. We have read about ion channels and all, either by diffusion or the ions through the ion channels, or by, if it is energy mediated, through the pumps like sodium potassium ATPase pump. That is one example. So these are the ways that the substances can be reabsorbed into the blood, back into the blood. Same ways, energy mediated secretion, some can occur secretion. Secretion means from the blood side, it will come to the tubular lumen and it will be added to the urine. Okay. Now things are not actually so simple. Some substances reabsorbed, again secreted, again reabsorbed. These things will occur, but the concept is that either reabsorption means transcellular or paracellular. Transcellular means by active diffusion, diffusion, simple diffusion, or energy mediated active process or passive process diffusion through ion channels. They will go to the blood in the peritubular capillaries. In case of the juxtamedullary lymph nodes, the same thing is the vasa recta. And when the substances, same side, this we have done in general physiology, just recall, if sodium and glucose following the same direction, then that is called an example of symport. If sodium going in one direction, hydrogen in other direction, then it is antiport. So this is either by means of symporter and antiporter. In the proximal convoluted tubule, what happens? Most substances are reabsorbed mostly like most of about 6 total reabsorption of sodium 68, 67, 68%, almost 70% occurs in the proximal convoluted tubule. So how is glucose? Most of it, almost 100% is reabsorbed in the proximal convoluted tubule itself. So that is done, glucose goes along with sodium. So sodium glucose symport occurs in the apical side, and then there are glucose for delivering glucose, there are GLUT channels for this glucose, which is going through the basolateral side. It is being reabsorbed into the blood. So mostly glucose, almost which substance? 100%, almost 100%, if not total 99, 100% is going through in the proximal convoluted PCT itself, that is glucose. But most of sodium, 60, 70%, much of the water and all. So these are the characteristics. How in the late distal convoluted tubule and the collecting tubule, usually without the action of ADH, what does not occur? The reabsorption of water does not occur. In the characteristics, reabsorption characteristics in the late distal tubule and the collecting tubule, reabsorption of water occurs only when ADH is acting. When ADH is not acting, then a diluted urine is formed. When ADH is acting, then concentrated urine is formed. And this difference in concentration and dilution due to ADH is, the ADH is acting in the late distal collecting tubule and the convoluted tubule and the collecting tubule. This is again from a very standard textbook. This will be required again, we just as we go on into the discussion, as well as our understanding of the counter current mechanism, in which portions of the tubules, what are the characteristics of reabsorption. Like you see proximal tubule, plus means proximal tubule transport. This transport means active transport. So active transport occurs of NaCl, sodium chloride. Here they have shown it, 0 means it does not occur. In the thick ascending limb, okay, thick ascending limb, water is not reabsorbed. But in the descending limb, it is very much permeable to water. And water channels are known as aquaporins, very much permeable to water, thin descending limb. But thick ascending limb, it is more or less impermeable to water. During the counter current mechanism discussion, this will again be required. Okay, that how is the counter current or the hyperosmolarity of the renal medulla maintained. Medulla means the tissue space. So these tubules are going, and the side by side the vasa recta or the peripleural capillaries are going. But there are this is in the interstitial space, that renal medulla interstitium, how it is remaining concentrated. So these factors will work. Okay, these factors, in what factor? When under the water is absorbed, we told distal tubule, cortical tubule. This plus ADH means it is reabsorbed only under the action of ADH. Same holds for urea. Urea reabsorption can also occur. That is, same holds for urea in the last part, inner medullary collecting duct. Just think of the loop of Henle. Inner medullary means in the deeper into the medulla, that portion of the collecting duct, urea reabsorption under the action of ADH. But urea reabsorption does not occur in the thick ascending limb or the distal tubules. In the proximal tubule or the descending limb or the thin ascending limb, it is one single plus here, means it is to some extent it is reabsorbed, but not mostly. That is, permeability to water urea is increased or decreased by ADH in the last portions. Last portion means the distal tubule, cortical collecting tubule, inner medullary collecting duct. Out of that, urea only in the deeper parts. Okay. So again, urea also has a role in concentrating the urine, that will come to. So this will just help. We will just refer to this slide again and again. So this just leave, mostly water is filtered, percentage of filtered road reabsorbed, most except urea. Urea 50% is reabsorbed, 50% is going out, and it contributes almost to the urine 600 milliosmoles per liter of urine. Single substance which contributes this much. What is the highest concentration of urine which can achieve in the human body. The human kidney can achieve up to 1000 to 1200 milliosmoles per liter. Above this it cannot concentrate. So if say somebody has to pass out 1.8, this is the concentration of solute. This is out of our discussion. Concentration of, at the moment we should concentrate on reabsorption part only. 1800 milliosmoles, say somebody has to be given out through urine solutes, 1800. So minimum amount of urine has to be formed is 1.5 liter. 1800 by, did you get it? If it is 1200 milliosmoles of solute per liter has to be excreted, any solutes means say any sink of any toxic substance, it has to be excreted so much. So total can be achieved is 1200. Out of that 600 is taken up only by urea. So if excess NaCl has to be excreted, very excess, then the urine volume has to be increased. Almost say 1200 is contributed by NaCl itself, which is actually not. But if NaCl, say salt ingestion is increased, if it increases, then the amount of that has to be excreted, then the kidney has to excrete more amount of urine or more amount of water to excrete that same amount of solute. Not amount, the same solute, if its concentration is increased. So then the body gets dehydrated. Just interesting that if we, instead of drinking normal this water which we drink every day, if someone drinks a lot of seawater, it is not a practical example, no one is, that means in cases of drowning and all, what happens? Even if the person recovers, dehydration has occurred because the kidneys is trying to excrete that excess NaCl. For that, it has to excrete more and more water because it cannot concentrate urine beyond a certain concentration, 1200 milliosmoles per liter. So if the total amount of solutes to be excreted per liter becomes say 2000, so along with it more and water has to be excreted by the kidney. So this leads to dehydration, like in cases of ingesting salt water. This is just an example. We'll concentrate on reabsorption now. So this is in the first half of the proximal tubule. Some characteristics are different in the first half and the second half of the proximal tubule. See, we already mentioned glucose enters with sodium through symport SGLT2 channel, sodium glucose cotransporter. In cases, SGLT2 is a example which we will require further when you will study about the medicines on diabetes and all. SGLT2 inhibitors. That SGLT2 inhibitors, they help to that glucose reabsorption. Glucose reabsorption occurs. So glucose reabsorption has to be lessened. Some drugs are there which inhibit this SGLT2, so that glucose is not reabsorbed, excreted more through urine. So that is one application of this. So this SGLT2 is present in the first half of the proximal tubule, and the glucose is finally reabsorbed through the basolateral membrane through the GLUT2 transporter. GLUT2, I think this is not an ion channel. Okay, this is not channel, this is transporter, GLUT2 transporter. Okay, sodium and say hydrogen. When sodium is reabsorbed, it is through the sodium hydrogen antiporter. So even if you don't remember all the names in particular, even if you can't, then you just write there sodium hydrogen antiporter. This much you can write. Whatever is going in the opposite direction, just write it is antiporter. When you can't remember the names, there will be so many names, maybe it will not be possible to remember. So write this as sodium hydrogen antiporter. So instead of one sodium going, hydrogen is one secreted. And where does the hydrogen come from? From the cellular respiration, from the Ca2. And HCO3 is reabsorbed, and this sodium is going out through the basolateral membrane in exchange of one potassium. But the electrical neutrality has to be maintained. So even if you don't show, when you are writing about sodium reabsorption, even if you don't show this, it is better to show, because this potassium cannot remain as such. Electrical neutrality has to be maintained. So this potassium again will be going out through a potassium channel, but at least show the sodium part. Sodium is going through the apical membrane through an antiporter. If you don't remember NHE3, there are various subtypes NHE3, NHE. So if you don't remember, just write sodium hydrogen antiporter. In this case, write what it is. It is written ATP, but better to write sodium potassium ATPase. This is the commonest which you have known from the days you are reading, the days you have studied general physiology. Sodium potassium ATPase. So sodium is reabsorbed, and along with sodium, glucose is also reabsorbed. This occurs in the first half of the proximal tubule in the same areas, but just to show it, they have just made it A and B. This is from again a very standard textbook of physiology. So A and B. So this is just for showing. This whole thing is occurring in the same area, sodium and glucose transport. And after the first half, leave this percentage distance along proximal tubule. As the proximal tubule, along the proximal tubule, most substances are reabsorbed. Glucose almost 100%. What is less reabsorbed, that is chloride and all, so they still remain. So leave this. This is in the second half of the proximal tubule. Again, some other mechanism, sodium hydrogen, the sodium is going out in the reabsorbed in the same way, but some instead hydrogen is coming back. Hydrogen and some bases are just coming out of the cell, and again they are going back. This H base from the hydrogen and base, and this base, any base, there are different bases, and they are secreted in exchange of chloride. And in the second half, what also happens is sodium chloride goes through the what we mentioned as the paracellular route. That means in between the cells. Not only, so some sodium chloride is also through the diffusing through the paracellular route, that is in between the cells, just directly from the apical side to the basolateral side. So this part is not. This is NaCl. Water along with some solutes. This is called water drag. Through the paracellular route, there are some amount of solutes are reabsorbed, and along with that water is dragged. This is called solvent drag. Okay. So water is reabsorbed and solutes are reabsorbed, some through the paracellular route. This is called solvent drag. So reabsorption of sodium, glucose, and in the first half, second half of the proximal tubule, and through the along with the water drag. This is shown. Some cations and anions and secreted, organic cations and organic anions. You don't need to remember all these names, you just remember these are the channels through which either energy mediated or non-energy mediated, instead of alpha Kg is alpha ketoglucarate. Wherever there is ATP, organic anions, this is secreted. Sodium potassium ATPase, again sodium and potassium are exchanging, sodium is absorbed, potassium is again this sodium is coming inside the cell, alpha ketoglutarate is going out, organic anions is first coming from the base. Whatever is secreted you have to show from the basolateral side to the apical side. You have to show it from the basolateral side to the apical side. Whatever is reabsorbed from the apical to the basolateral. So at least, even if you make many things wrong, don't make the direction of the arrow should be okay. Otherwise, it will mean totally the opposite. When you are writing about reabsorption, then the arrow should be from the apical direction. You can show the tubular lumen any side. If you show the tubular lumen on the right hand side, you can show the blood side on the left hand side. But usually follow the convention, tubular lumen is shown on the left hand side, blood side is shown on the right hand side. Here I have just added up just joined the two pictures. This is for organic anions, this is for organic cations. Just leave the actual names, you just write anion transporter or cation transporter, like that. This will not be, mostly it will be asked the reabsorption of the sodium, glucose and other solutes in the proximal convoluted. These are names of some anions and cations and some drugs which are secreted in this way. Secreted means whatever will not be filtered, the body tries to get rid of some drugs. Drug metabolites, they are not required in the body. So they are removed by secretion. This is in the thin descending limb. Again sodium, potassium, chloride. Here sodium, chloride, Na plus, K plus, 2Cl minus, these pathways are working. So if you don't remember NKCC2, just sodium chloride, these are not required. Sodium, potassium, chloride channels. And here sodium potassium OTPase chloride is going out on the basolateral side through the chloride channels. Again, some sodium through hydrogen, sodium hydrogen exchanger. If you don't remember NHE3 diet antipode, simply write sodium hydrogen antipode like this. And some will be some amount of substances, sodium, potassium, calcium, magnesium, whatever will be going out through the paracellular diffusion in that area also. Same in the different parts of the renal tubules, the different parts of the tubule. So here see sodium and chloride, again write sodium chloride, this is say not antipode, sympode, and this again on the basolateral side going through sodium, so going out through sodium potassium ATPase. So ultimate is about sodium reabsorption, okay, and potassium transport, potassium is coming for just to maintain electrical liquidity, potassium is going through the potassium channels and some through potassium chloride sympode together, okay. This is what is occurring in the last part, principal cells and intercalated cells, okay, principal cells and intercalated cells. What happens? Intercalated cells are of two types, alpha and beta. In the principal cells it is again, so it is about sodium potassium reabsorption. In the alpha intercalated cells it is hydrogen which is secreted, and in the beta intercalated cells it is what is secreted? Potassium, bicarbonate which is secreted. This will again come into discussion when we will discuss the acid base balance. So hydrogen secreted by the alpha intercalated cells, and these are the various HK. This is potassium hydrogen transport. So don't need to write the names or event. Don't write abbreviations, names, nothing. Just write antipode or sympode at your antipode or sympode. Okay. So H plus, this is H plus ATPase channel. Energy mediated H plus is secreted. Before that, it has to come through this. Where is the H plus? Source of H plus? Cellular respiration. So about so many milliequivalents of H plus, alpha intercalated cells are specially designed where this H plus secretion is occurring. Okay, if we have time, we will just consider about glucose reabsorption. Glucose reabsorption, we just told most of it under normal conditions it is reabsorbed, 100% is reabsorbed. So, but it is up to a certain limit. Okay, glucose reabsorption is up to a certain limit of plasma concentration. In the initial, the plasma concentration, what is the plasma concentration of glucose? Usually 80 to 100 milligram per deciliter. So what will be the filtered load of glucose per minute? That is filtered load of glucose per minute. How to calculate? This is the plasma concentration, that how much glucose is filtered per minute will require the glomerular, how much is the glomerular filtration for that, right? This should come into the mind instantaneously. GFR is 125 milliliter per minute. So what is the filtered load of glucose at usual this plasma concentration? This into this. But before that, deciliter, as it is, the units are different, deciliter, milliliter. So this is, you have to take it in a single unit, or you have to consider it into milligram per deciliter. So you have to multiply it by 100. Yes, this is. So 80, if it is 80, this will be in milligram per minute. So this is the filtered load. Now say glucose concentration in plasma, if it is increased, then the filtered load will increase. So it is seen the tubular, there is a term, the tubular maximum reabsorption, maximal reabsorption capacity. This varies for different substances. For glucose, it is theoretically almost near to 400, around 375 milligram per minute. So at plasma concentrations, normal plasma concentrations, whole of it will be reabsorbed, because my limit is tubular maximum reabsorption. This varies for different substances. Tubular maximum reabsorption. As well, there is a concept of tubular maximum secretion. Tubular maximum reabsorption, because this depends on these different channels, sodium glucose transporter, GLUT channels. This has a certain limit. This cannot. The body does not have and this out of extraordinary capacity. Whatever is filtered, that will be reabsorbed, but that has a certain limit. Above that reabsorption capacity, when it is exceeded, that will come out through urine. For glucose, that tubular maximum reabsorption is 375 milligram per minute. So at normal concentrations of plasma glucose, it is much less. Filtered load is 100 milligram per minute, so that will be fully reabsorbed. But if it is above this 375, then it cannot be reabsorbed theoretically. So again, this is theoretically above 375 cannot be reabsorbed. So if we plot plasma concentration of glucose, how do we look like? As the plasma concentration of glucose increases, the reabsorption fraction, filtered load increases. So if it is say 80, 100, 200, so as it is increasing, the plasma glucose, the filtered load, this also is increasing. But at say 375, it will not be reabsorbed, but it will be excreted. It cannot be reabsorbed, it will be excreted at 375. So where it should be? This should be at 300. Now just understand this should be at 300 milligram per deciliter of plasma glucose theoretically, because the glomerular filtration rate is 1.25. Just do simple mathematics. 1 is in deciliter, milliliter. Then I have to write the equation again. 3 is in 3 per milliliter. Per deciliter, it is 300. Just do that again. Plasma glucose concentration into, due to lack of time, I am not writing. Plasma glucose concentration into multiplied by the GFR is the filtered load. So for filtered load to be 375, which is the plasma glucose concentration at that time is 300. So at 300, after 300, everything will be excreted. So nothing will be reabsorbed. So the curve should actually be like this. So at this point, curve should actually be like this. Up to one point, it is reabsorbed and then everything is excreted. It is not possible to reabsorb. But curve actually does not become like this. The curve shows like this. At this point, it is curved. It is a little curved. This area is called splay. Splay means it is a difference, deviation from the original. This is because this 375 we are considering, this theoretical value 375, 300 we are considering that all the nephrons are equally working, that all the nephrons are equally working. Okay, that means they have the maximum capacity to reabsorb, but in actual all the nephrons at a point of time are not being able to, that means 100% efficiency, they are not working. Okay, just get this point. Why the curve looks this curve, this becomes curved, because 100% it is not possible. Okay, all the nephrons are not. So some nephrons are working less than their actual capacity. So what is actually seen at that? After 200 milligram per deciliter of plasma glucose starts appearing urine. Although it is 375 milligram per minute. Okay, 375 milligram per minute, the tubular maximum reabsorption capacity. Above 375 is not possible, but actually it comes, it will be 200 into 125. That means at 250 milligram per minute, it is not possible actually to reabsorb more than 250. 200 into 125 by 100. That means 1.25 in deciliter. 200 at 200 milligram per deciliter, above 180 to 200 milligram per deciliter, glucose actually starts appearing in urine, although it should have been at 300, because all the nephrons are not working to the maximum efficiency. So this, instead of this linear, this a straight curve and then the straight line, this there is a splay. Splay means in some individuals you will found it is at 200, at some individuals it is around say 220, around 180. So this deviation from normal, this is called the splay. So splay is asked in the, from the exam point of view it comes. So whatever is reabsorbed, whatever is excreted, and this difference between the deviation, instead of a straight line, it, that part when it up to say 150 and all, everything is, it will be totally reabsorbed. But above that it varies from human to human, how many, what is the percentage of nephron, or what is the efficiency of how much percentage of nephrons, these things come into view. So that area is called splay. So just draw that diagram and just plot plasma glucose milligram per deciliter on one side, glucose transport on the other side. Just write these words and describe splay. So this, from the exam point of view, this part is important. This comes as a question, glucose clearance. So you are left with the counter current mechanism and the acid base balance we have to discuss in short. There are many things. I think we will require 2 more classes for completing renal physiology. It should be more, but at least 2 more. One, it will not be possible in one.